Hello, my name is Daniel Orringer. I'm Associate Professor of Neurosurgery and Pathology here at NYU Langone Health. I wanted to start by thanking the course directors of the second annual Computational Neuroscience Data Symposium for the opportunity to speak to you about my work at the intersection of big data, histology, and brain tumor surgery. Having completed my fellowship at the Brigham years ago, many of the faculty and speakers here are my mentors and taught me much of what I know about medical imaging and data science. Here are my disclosures. I'll be speaking about a number of technologies that I have conflicts with, but I think those are managed appropriately, as you'll hear throughout the talk. So to start, in clinical practice, at least in neurosurgery and specifically in the world of brain tumor surgery, the interpretation of medical images is largely subjective and builds on human experience and expertise and intelligence. While this is largely a reliable system, like any system based on human factors, there are limitations, biases, and failure modes. As our tools for image and more generally data analysis become increasingly sophisticated, the use of quantitative analysis of medical images will enable better clinical decision-making, ultimately resulting in better and safer care for our patients. In this presentation, I'll cover the development of new tools for digital histologic imaging, as well as advanced analytic tools which bring the images alive. The story started in Boston in the mid-2000s in the lab of Sunny Xie, where a new imaging method was developed called stimulated Raman scattering microscopy. And I also worked in Sunny Xie's lab during my fellowship at the Brigham in 2011. And I found during that time that my colleagues in Sunny's lab were interested in exploring clinical applications of SRS microscopy and developed a system ultimately for doing SRS imaging in a medical setting. With a lot of hard work, they built a system that is now in clinical use in several centers across this country and within the next year in Europe as well. What makes this imaging technique unique is that tissue can be imaged without the need for processing or sectioning, making it very easy to access histologic data without the need for a pathology lab. Because this technology is so different than other histologic methods, seeing it in action makes it a little easier to understand. So this video shows how the imaging system can be rolled out into the OR. You'll see that the system is brought into a position where the surgeon can access the images from the operative field, and how it creates a unique class of data that can be integrated into the decision-making process in the operating room. Tissue can be removed directly from the operative field, as you see here, handed off to a nurse or technician in the OR who will place the tissue into the carrier and load it into a machine. The user of the machine then sets up the scan and images come up on the monitor. You'll see those images pop up shortly in the video. Because the surgeon has a lot on his or her mind, and because histologic images contain a huge amount of information, we rely heavily on image analysis to ensure that the data created by the imager comes to life and can be easily integrated into the goals of the operation, whether that goal is simply establishing diagnosis or ensuring maximal safe resection. Here you'll see as the images come up, they're processed, and using TensorFlow, as you can see here, we're able to render a diagnostic prediction about the most likely etiology of this patient's tumor. So the images this system creates are natively digital, and starting with the earliest days of the project, we worked to quantify them. When I was her fellow, I went to Dr. Golby with some images from the early system we were using that I was excited about. She essentially said, these are pretty pictures, but you need to figure out a way to quantify them. The editors at Science Translational Medicine said the same thing. And our first foray into SRS data analysis was born. This figure shows the very basic quantification of the CH2 to CH3 ratio in the bonds that we're imaging as we move across the field of view from normal brain to tumor. As we imaged more and more, we realized that morphologic information could also be useful in detecting the presence of tumor. And a number of brilliant University of Michigan med students working in my lab developed increasingly sophisticated ways of using cellular and axonal quantification techniques to combine with biochemical information to train a classifier to differentiate tumor from normal brain in this 2015 paper. Another student, Balaji Pandian, Harvard CS alum, brought AI into my lab for the first time back in the mid-2000s. And deployed a multi-layer perceptron to differentiate intrinsic and extrinsic tumors, as well as tumor grade in the SRH images of brain tumors. Balaji collaborated with my brilliant postdoc, Todd Holland, who's now a faculty member at U of M, to harness the power of convolutional neural networks to classify brain tumors into the 10 most common diagnoses and to determine when they didn't fit into a category very nicely. So with an increasingly big ask of our algorithms, namely 10-class multi-class classification, we needed to provide an increasingly robust training set. To train our CNN, we generated over 2.5 million patches from 415 brain tumor patients. And I think this is a key point and holds important implications for deploying AI in the neurosurgical space where we deal with rare diseases, commonly those that occur on orders of magnitude less than hypertension, diabetes, or heart disease, whereas glioma typically only occurs in 20,000 cases a year. The ability to employ big data techniques in medicine seems to be a product of the disease incidence and the depth of the training data. In our case, although we're studying an extremely rare disease, because our data set is so rich enough to generate 2.5 million patches from 415 patients, we can deploy big data techniques. Histologic images are unique in that they're extraordinarily rich in information, with a standard 3x3 SRH image containing over 60 million pixels of data, which can be accessed for training. With each patient providing approximately 3x3 millimeter scans, our training set contained about 74 billion pixels, with each pixel representing an individual spectral measurement. For me, it was notable that a group of a little more than 400 of our brain tumor patients could yield such a large training set. Armed with a CNN that appeared to perform well on validation and test sets, we set out to execute a prospective multi-institutional trial to see how it could perform in an OR. Our workflow for the trial was as shown above. We tested the CNN on our images acquired from 3 SRH imagers deployed at 3 institutions across the country. Notably, the images from each center were indistinguishable to pathology reviewers. The lack of dependence on a specific processing, sectioning, or staining technique enabled this remarkable degree of consistency across centers. The trial design was simple. We took fresh tissue specimens, cut them in half, imaged half with the SRH imager, and obtained interpretation from the CNN. The other half of the tissue was sent for conventional histology and interpreted by board-certified neuropathologists. And I should note that this study was led by this brilliant postdoc I alluded to earlier, Dr. Todd Holland. In our study, we enrolled and analyzed 278 patients undergoing brain tumor surgery at 3 institutions. Accuracy was above the 90% threshold set as a benchmark by the College of American Pathologists. The overall accuracy of the conventional histology plus pathologist arm was 93.9%, with pathologists miscategorizing 17 of 278 cases. The overall accuracy of the SRH plus CNN arm was 94.6%, with the CNN miscategorizing only 14 of 278 patients. Notably, the errors in the 2 arms were entirely non-overlapping, meaning that the CNN might be useful in improving the accuracy of pathologist-based brain tumor diagnosis, and that if an expert neuropathologist were not available in a smaller center, for example, the CNN might be able to assist in diagnosis. Looking ahead, we've continued to dramatically increase the size of our training set. Our current training set includes around 200 billion pixels, and we anticipate that we can juice a lot more from our data set, more than morphologic data. With the increasing centrality of molecular data, driven by a pair of publications in 2015 in the New England Journal of Medicine, we've understood that there are several genetic subtypes dictated by IDH, 1p19q, and TERT, and that these molecular subtypes actually predict survival better than grade amongst grade 2 and 3 glioma patients. Our preliminary data suggests that we're able to predict these genetic subtypes using AI and SRH with an accuracy of greater than 90%. Our vision for the future includes a pipeline where fresh brain tumor specimens are imaged with SRH, processed by the CNN, run through a feature extractor, and subjected to a sequential binary long short-term memory network to predict the likelihood of key genetic classifications. We also recognize the limitation of existing genetic classifications of gliomas and understand that classification systems will evolve, some of which will rely on methylation clustering, for example, that may become increasingly central to brain tumor diagnosis. Our larger aim is to generate a pipeline for CNN training that can be easily updated to reflect emerging systems for tumor classification. We've also recently appreciated the power of unsupervised learning to predict previously unknown prognostic determinants of gliomas. Using a clustering method on our SRH image low-grade glioma dataset, we identify 3 clusters that align well with genetic subtype and increasingly, but not surprisingly, less well with morphologic criteria. The cases we're most interested in are those that the AI associates with, quote, wrong genetic cluster, are those that quote, misclassified cases of patients who might have a prognosis that is unexpectedly long in the case of IDH mutant tumors with ATRX loss that the algorithm puts into a cluster predominantly with 1p19q co-deleted tumors. In this manner, we feel unsupervised learning can become a method for generating a more nuanced understanding of human glioma classification that goes beyond just morphologic and genetic criteria alone. I apologize for going a bit over, but I wanted to end by thanking my chair, Dr. John Golfinos here at NYU, my close pathology collaborator, Matthias Snuderol, and Dr. Todd Holland and Siri Kalsa, who have driven a lot of this work, as well as my collaborators at Invenio Imaging, Chris Freudiger and Jay Troutman, as well as Steve Pastor and Balaji Pandian. Thank you.